Hey, there we go. Hi, welcome to Mad Medicine with Miss P. That's me. Okay, today we're going to talk about ACE inhibitors. So I know we did beta blockers last week, and I wanted to get through ACE inhibitors this week and maybe calcium channel blockers next week, just to kind of give you an idea of how they work. A nurse friend of mine and I were talking today. Hey girl, ran into you Marshalls today. How you doing? We were just talking about how important it is that you learn not just what the classification means, but how they work. You know, I know in school they kind of teach you like classification, side effects, nursing implications, and like uses or indications. They don't really concentrate on action. Like I said last week, action really is everything. How it works in the body will tell you what it's going to do. So those are your side effects and your nursing considerations, right? Those are the things you're going to look for if it does it too much or not enough, your nursing, considerations and how you're going to treat these patients. So the action is what matters, is because if you understand a little pathophys, a little of how the body works in general, anatomy and physiology, then you know where these meds work and where they don't. Now, ACE inhibitors are a little tricky, and I don't know if I'm going to be able to explain them by sitting still because I really need to move. I usually, those of you who know how I explain ACE inhibitors, I really have to elongate the room, but I'll try to do it sitting still. So the way ACE inhibitors work in general are they can kind of do one of a couple different things, or a few different things. You can either stop renin being released from the kidneys, or because renin causes angiotensin 1 to convert to angiotensin 2. Otherwise, I looked it up out of curiosity, angiotensin 1 really has basically no function in the body for the most part. It just kind of wanders around waiting to be turned into 2. So when angiotensin 1 is converted to angiotensin 2, that's the problem that goes and causes vasoconstriction. So you can do a couple things here. You can inhibit renin being released from the kidneys, kind of like what metoprolol does, still a beta blocker, but it works on blood pressure a little bit more so than you'll see for heart conditions because of that property. Or you can block angiotensin 1 from converting to 2. You can neuter 2, kind of stop angiotensin 2 from doing what it's supposed to do, or inhibit angiotensin 2 itself. Or you can block where 2 kind of plugs into those receptor sites, right? So those are your ARBs, angiotensin 2 receptor site blockers, like Cozar, Divan. There's one other that is real common. Oh gosh, it's escaping me. Dang it, do I even have it written down? No, probably not. It'll come to me as soon as I turn off the camera. So those types of ARBs will stop your Cozar. Sorry, I gotcha. So those things kind of block what angiotensin 2 wants to do, versus lisinopril. You know what? I have a list of those. They're on my phone, so I can't get to them right now. But all of the prils tend to kind of stop that chain of events somewhere in here, and it doesn't necessarily even matter where. It doesn't matter if it inhibits renin, stops the conversion of 1 to 2, makes 2 inactive, or the ARBs that block it. Your bottom line is you're stopping one thing and one thing only, and that is in fact vasoconstriction. So when somebody comes to the emergency room, very rarely are you going to hear someone quick with the ACE inhibitors. That's not how it works. That's just stopping things from getting worse. Very rarely will we hurry with the beta blockers unless there's a heart condition also. It's not to say you can't, pump them with a little IV low pressor, to kind of see how it's going to work, a little Trandate, and see what it's going to do. And you can get that effect in IV doses, but no one's like, quick with the PO 10 milligram or 40 milligram lisinopril, and let's wait to see what happens. That's not how that works. That's why when someone is 110 over 63, I'll still give them their lisinopril. I'll still give them their ARB, their Cozar, their Hyzar, Diavan, they're still going to get all those meds because it's not going to significantly drop their blood pressure. It's going to stop it from going higher. Now, if that's their first dose of that medication, then yes, if I took it, yes, it would drop my blood pressure because I don't have a constriction dilation problem. My body's regulating it as it should. And I know that because I check my blood pressure very, very often. So I know about what normal is for me. Now, remembering that blood pressure changes with every beat of your heart. And when I come home and see my daughter's room, my blood pressure may go up a little bit, or the bathroom, or the kitchen, or what my puppy has done to the house, or how my older dog is now knocking all the stools over and still getting her fat butt up on the couch where she knows she's not allowed to be, right? So in that case, my blood pressure may go up a little bit higher. So it's not to say that if I didn't take a lisinopril at that time, that it wouldn't drop it. And that's why you see those doses at like 2.5, 5, 10, 20, and 40 milligrams. That's about where you see. And I've never seen, a significant, like, I don't know, there's probably 100 milligram lisinopril. Is there? I don't think so. I don't know. I got to think about it. But these are the things that, if you understand how they work, then you know when to give them and when to hold them. And when we're done with all of the antihypertensives, we'll talk about when you give and when you hold and why. So because you're not always going to have a nursing instructor there to tell you what you're giving and what you're holding and why, because you may not even have a physician there. You're going to have to be in the room alone with all these meds and have to decide. You're not going to have the time to send a text and then wait to see how long it's going to take them to get back to something that is not an emergent for your 9 o'clock meds, right? So if you understand how a beta blocker works and ACE inhibitor works, then you'll realize when you go in there with metoprolol, you got 25 of metoprolol and 40 of lisinopril, and the blood pressure's 136/72, I'm going to give them both. Yeah, if you know how they work, you know that they stop things from getting worse. Your beta blocker is going to stop that sympathetic nervous system from responding when you come in later with a needle, and that lisinopril is going to be on board doing what last night's dose was about to wear off to do, and then you're going to give, today's dose or yesterday morning's dose if it's, once a day, depending on their half-life and how they work. So, before he has a chance to rebound hypertense, you're going to give that med that says, no, we're going back and stopping vasoconstriction, and you're staying right where you should, nice and steady. When you see a patient that has a crazy blood pressure that morning, and I see it a lot, so much that's like one of the reasons why I had to quit teaching, because I didn't know what else I could do, and I'm a guest in these facilities. So when the student comes to me and they say, the patient's blood pressure is 186/104, and I told the nurse, and she says, okay, well, we're going to go ahead and give the morning meds. And I know two nurses out there thinking, you're like, yeah, let's give the morning antihypertensives and, everything's going to be fine. Well, like I said in previous videos, if they're on those medications every day, why aren't they working? There's never a time that blood pressure should be that high. We are not babysitting them until they die. We should be monitoring them and not allowing that to happen. And this is not necessarily in the hospital setting, because, when they're in that acute, critical care site or that just acute care area where they're sick for these 3 or 4 days, we can make them better and send them home. But like the long-term care facilities, they should never be that high. And that's what the nurse says. And sometimes the nurses are my previous students, which breaks my heart a little bit, because I know that I have drilled that into them. Never is there a time that their blood pressure should be that high at 8 o'clock, 9 o'clock in the morning. By the time we get to the floor and we check their blood pressure, that means, yes, last night's doses have already worn off, or yesterday morning's doses, if they take it just once a day, has worn off. Well, when did it wear off? Did it wear off at 4 a.m., at 6 a.m., 10 minutes before we walked in the room, or did it wear off at midnight last night? And no one's checking their blood pressure during the night. So they had this window of pressure cleaning their kidneys, obliterating the capillaries at the most distal end, and where capillaries reside, and a risk for stroke. So that's not okay. If they're on those medications and they're not working, do something else. If you gave that patient a narcotic at 9 a.m. and they started complaining of pain at 8 p.m., you wouldn't be like, well, you get it once a day, so just writhe in pain until tomorrow morning. You would do something about it. So just because you can't feel your hypertension and you don't know about the permanent damage it's doing inside, that's okay. It's not okay. Those medications should be doing their job. And more often than not, my patients coming in for surgery in the morning, they took their beta blocker at 5 o'clock that morning. It's now, 10:30. I'm getting them ready for surgery and their blood pressure's crazy. And they're like, well, I'm just really nervous. But that was the point of the medication you took earlier. That beta blocker you took earlier, that's a beta adrenergic blocking agent. That is supposed to stop your sympathetic nervous system from responding in such a crazy way. Yeah, it's going to go a little high. You're anxious, nervous, worried, upset, scared, and pain. Sure. But 210 over 114, no. That beta blocker, you might as well have taken a Tic Tac, because it's not doing anything at all. And you are currently at risk for stroke, permanent kidney damage, not just a stroke, but any bleed anywhere. You can have a hemorrhagic stroke. You could have, who knows, you can have an aortic something or other going on that's just, waiting to bust. How much pressure do you think your vessels can tolerate? And worst case, it was just like a patient I had the other day, and God bless him. There's hope for him. He listened, he was appreciative, and he even said like, okay, it sounds like you know what you're talking about. I'm like, yeah, I really do. I'm like, I'm the blood pressure police for a reason. His blood pressure was insane. He's like, yeah, it runs high. And my doctor says I'm borderline. I'm like, oh, okay, don't. But so I just went to town on the whole doctor borderline thing. Right. Well, your doctor right now, he's out on his yacht in the Caribbean with his much younger girlfriend and maybe his children. He doesn't give a crap about your blood pressure because borderline. No, I might be borderline. You know, borderline crazy, borderline insane, borderline OCD. You have uncontrolled hypertension, and what's currently happening right now to your kidneys, whether you like it or not, is going to continue to happen until you get it under control. And it's not about pills. It's not about meds. I'm never a med pusher. There's 100 other things you can do. I believe your brain is the strongest organ in your body, and the way you handle stress and the way you think about things and the way you can control it. There are very high stress people out there that don't have hypertension. My husband has a very high stress job. I swear like you would think that his little head's going to pop clean off his shoulder and leave a bloody spot on the ceiling. But his blood pressure is always 116/63. It's insane. So your brain can handle it. It doesn't mean you have to have medication all the time, but if you're not having controlled blood pressure, you need something that's going to control it. So as I, got done talking to this guy, and the number one thing that I can use to kind of, my telltale sign, like I said in previous videos, is that I show them the numbers, and they're crazy. They're always 200/100 and something. And I say, okay, so right now, do you have like a bad headache, any blurred vision, photophobia, is the light bothering you, any dizziness, any, blurred vision, all these things? And, he's like, no, I feel fine. Yeah, that's because your body's so used to it. It's not even flagging you. It's not even telling you something's wrong. That's a really bad sign. That's really not okay. And this is what these meds do, right? So they take them in the morning, like, oh, well, I already took my lisinopril and my metoprolol. Okay, they're here are your numbers, and they're not working. So it doesn't matter what you took. You could have had a handful of grapes if you wanted to, because you're going to have the same effect, or even worse. What would those numbers be if you didn't take those meds? What happens then? So I don't want to scare them. I don't want to freak them out. Not like I haven't been spoken to about that before, but I want them to know how important it is. Because just like I told Julie today, everyone's wearing their red ribbon, right? We all know how we're going to die. Everybody's aware of their heart disease, cardiovascular disease. You got your red ribbon awareness. We're all aware. We all know how we're going to die. Okay, good. No one's going to do anything about it, but we're all going to die. Okay. That's not helping anything, right? So you need to know how these medications work so you know what to give, what to hold. And if you gave them and they're not effective, do something about it. Tell your doctor, like, hey, this handful of Tic Tacs you're ordered for him every morning, they're not working. The blood pressure's still out of control, and we still have numbers that we're concerned with. That bottom number should never be above 89, not for any reason. Maybe if someone's asking for your purse in a dark alley at gunpoint, in the dead of night, okay. But even then, who's checking your blood pressure? So you wouldn't know. So otherwise, you can't think that these medications are doing their job, right? So if we stop vasoconstriction, we're just stopping things from getting worse. It doesn't necessarily cause vasodilation, but it may allow some vasodilation. So like what I talked about last week is that the reason we want those 2 doses of an ACE inhibitor held before a general anesthetic is because when we can control everything and calm everything down and make it all cool and quiet and relaxed, well, then when your body's like, okay, yeah, I'm nice and cool and relaxed, and that's pretty neat, but I'm going to need to constrict a little bit because I need some perfusion to the brain and all the way to the toes against all this pressure, all this meat, all this adipose, and everything blocking me and stopping me. So I'm going to need to constrict a little bit. And when that ACE inhibitor's on board, they're like, sorry, can't allow that. He's like, no, you don't understand it. It's really important. I need to constrict, or things are going to start, falling off the poor man. So that's why the CRNAs ended up, pushing, I guess, I don't know, no CRNA, ephedrine, or, whatever, they bump them with, what's the other one to wake them up a little bit? Oh, good God. Anyway, so they're going to have to give them a little something to, to allow them to constrict enough to perfuse. So if you understand how ACE inhibitors work, then you understand why they would want to hold them. And you can explain that to a patient. And that's what I say. I don't say, they drop your blood pressure too low. No, you are dropping your blood. The general anesthetic may be dropping your blood pressure too low. This is just not allowing you to constrict to bring your blood pressure back up where we need it to be able to perfuse correctly. And that's really all there is to ACE inhibitors. It's not that tricky. The only thing is you got to really watch those ACE inhibitors with your renal failure patients, because if you are inhibiting renin being released from the kidneys, that's the same as kind of going in there and telling the kidneys, hey, listen, you know how you normally function by releasing renin? I'm going to need you to stop that function. So you're kind of in turn inhibiting some functioning of those kidneys. So if the kidneys aren't already functioning well, you may not want to have this patient on ACE inhibitors. Not that we are out there, ordering meds, but when you see that and read the HMPs, and that's how I learned it. I swear to God, when I first started working in the hospital, I was just as oblivious as your average brand new student, because I hadn't done it in so long, and I had been working with healthy patients, other than the in the jails where they were just on drugs and they were not necessarily unhealthy except for their seizures. So I had to kind of read through these HMPs, and the more HMPs I read, and I read and read and read, and I mean, we're talking like I read 12 a day, every day, 3 days a week for, almost 15 years. And I mean, like, consistently. And then I read all the progress notes, and and kind of continued to see how they're getting better or worse and what we're doing about it. So if every time I saw a patient come in with acute renal insufficiency or acute kidney injury or whatever it was, and they're like, hold all ACE inhibitors, I'm like, well, why? Then I learned how they work and started looking through, and that's how I found out how directly related kidney failure is with thyroid function. Because every time I had a patient with chronic kidney disease, there's synthroid. Chronic kidney disease, synthroid. Kidney disease, synthroid. Lasix, synthroid. Lasix, synthroid. I'm like, okay, there clearly is a connection. Just like magnesium, cardiac disease. Magnesium, I'm like, okay, clearly there's a connection, right? Zinc and skin disorders. Zinc and ACE and ulcers, right? So eventually, when you see them together often enough, you're going to put 2 and 2 together. It's not that tricky. So that's kind of how ACE inhibitors go. It's really not that's involved. I don't even think I have anything else on. I literally didn't write that down. That's weird. I'm going to have to, I got calcium channel blockers and diuretics to hit, and vasodilators, which are really that simple. I could probably cover them today. They dilate your vessels, the end. Those medications are the things that when you see